Um, Imagine for a second that you are a nurse midwife.
Okay.
You're running a rural district clinic, and you are solely responsible for like 15,000 people.
Wow, that is a staggering number.
Right. It really is. And you are just staring at this ledger of maternal mortality rates that are steadily climbing.
Because you lack basic sterile equipment, I imagine?
Exactly. You don't have the gear to safely perform emergency deliveries. And the worst part is, you know exactly what you need to fix it.
But the funding isn't there.
Nope. Because the Central Ministry of Health just spent your entire annual district budget on this massive, highly publicized international donor-funded malaria eradication initiative.
Oh, wow. Let me guess, your district doesn't even have malaria.
Bingo. You haven't recorded a single localized case of malaria in 3 years.
Yeah.
So you have the clinical knowledge to save lives, but structurally, you have basically been engineered to fail.
It's a devastating reality, and honestly, it happens every single day in these settings.
Yeah.
The architecture of the system essentially dictates the survival of the patient long before a clinical intervention is ever even attempted.
Which is exactly why we are dissecting this today. Welcome to the deep dive.
Glad to be here.
And we are speaking directly to you, the listener, whether you're a medical student, a junior doctor, a public health trainee, or a practicing clinician.
You already know the clinical pathology of disease.
Right. But today, our mission is to examine the pathology of the systems tasked with fighting them. We are mapping out the complex mechanics of training public health professionals in developing countries.
And we're using Chapter 11.8 of the Oxford Textbook of Global Public Health as our structural spine for this.
Yes, exactly. But, this isn't just a textbook summary. Consider this your conceptual companion to the text. We are tracing the pathway from risk to exposure to systemic intervention, but entirely through the lens of human resources.
Because capacity building is structural prevention.
Ooh, I like that.
Yeah, I mean, that is the core framework we really need to operate from today. If you look at public health through a strictly clinical lens, you're just treating symptoms.
Right.
But when you look at the workforce pipeline, you are looking at the immune system of the nation itself.
I kept thinking about this in terms of like a massive electrical grid.
Okay, walk me through that.
So national policies, the central ministries of health, they are the central power plants generating this high voltage energy.
Yeah, the big directives.
Exactly. But the district clinics, they're your local transformers. And the village health workers are the final wiring running directly into the homes.
Yeah.
So it literally does not matter if the central plant generates a massive surge of policy or funding.
Mm-hmm.
If that local wiring hasn't been built by appropriately trained technicians to handle that specific local voltage,
The lights stay off.
the lights stay off.
Yeah.
Building the workforce is literally building the infrastructure.
That grid metaphor captures the asymmetry of the challenge perfectly, I think. Because developing nations are operating under the tightest financial constraints, right? Yeah. And the highest disparities in wealth.
Yeah, it's extreme scarcity.
So logic would suggest that to navigate that kind of severe resource scarcity, these health systems require the most robust, highly specialized, and, hyper-adaptable public health workforce imaginable.
They need the best of the best.
Exactly. Yet the systemic barriers to actually training, deploying, and retaining that workforce are almost paralyzing. The mandate placed on these systems is just staggeringly broad.
Yeah, staggering honestly feels like an understatement when you actually list it out.
It really does.
If you are operating a health system in a low or middle income setting, you aren't just managing hospitals.
No, not at all.
You are responsible for ensuring safe municipal water supplies. You're running maternal and child health services across these vast disconnected geographies.
Often with terrible roads.
Right. You're coordinating cold chain logistics for immunization coverage. You have to manage the safe disposal of human waste to prevent cholera.
And at the same time, you're fighting traditional infectious threats like TB, malaria, HIV.
While simultaneously trying to absorb this rising catastrophic wave of chronic diseases.
Yeah, the diabetes and hypertension epidemic is hitting them hard now, too.
It's an impossible list.
And that immense breadth mandates a completely multidisciplinary reality for public health training.
Right. It can't just be medical.
Exactly. A purely clinical biomedical approach will fundamentally fail when the root cause of an outbreak is, say, an unpaved road preventing access to a clinic, or a contaminated well.
You can't prescribe a pill for an unpaved road.
You really can't. You cannot tackle structural poverty with a stethoscope. So the workforce has to synthesize microbiology with management, physical sciences, political science, and epidemiology.
Which means the personnel required to manage this grid are drawn from all over, right? Nursing, medicine, environmental science.
Yeah, functioning across a massive spectrum, from basic community certificates all the way up to doctoral level policy analysts.
Okay, so I was reading the introductory section on how these training systems were historically designed, and I found myself getting incredibly frustrated.
Oh, the historical mismatch.
Yes, the text details this mismatch. Basically, many of the public health curricula currently used in developing nations are essentially just copy-pasted hangovers from European colonial systems.
Which is wild when you think about it.
It strikes me as structurally absurd. If a European curriculum was designed for a European model of disease where, the primary focus might be chronic care management within a highly funded centralized infrastructure,
Right.
deploying that in a rural African or Southeast Asian context is like giving a structural engineer the blueprints for an igloo when they're standing in a hurricane zone.
That's a great analogy.
The physics of the environment are entirely different.
It is a catastrophic failure of contextualization, truly. When you import a training program from a vastly different socioeconomic reality, you are just ignoring the immediate localized health burdens of the population.
You're training them for a world that doesn't exist for them.
Exactly. A curriculum built on the assumption of infinite resources, seamless electronic medical records, centralized high-tech sanitation. It leaves its graduates completely paralyzed when they are deployed to a district where the primary diagnostic tool is a paper ledger.
And the immediate crisis is a lack of potable water.
Right.
Which means the planners have a massive imperative here. Training can't just be about passing a standardized test on epidemiological theory.
No, it has to be practical.
It has to equip trainees with the cognitive flexibility to devise new strategies for shifting hyperlocal problems.
Yeah.
And, maybe more importantly, you have to build an incentive structure to keep them there.
Yeah.
Because you can train someone to build a hurricane shelter, but if you don't give them a career path, they're going to take those engineering skills and move to a safer climate.
They absolutely will. And the structural design of these health systems attempts to manage that reality, though often with a lot of friction.
So let's look at that architecture.
Yeah, the text outlines a 3-tiered blueprint for government-sponsored public health in these developing countries. And as we evaluate these tiers, it is critical to observe the inverse relationship between the density of personnel and the level of systemic responsibility.
Oh, okay, what do you mean by that?
Meaning the weight of the system is distributed very precariously. The top has the power, but the bottom has the numbers.
Oh, okay. Let's trace a policy down through that pyramid to see where the friction actually happens.
Let's do it.
We start at level 1, the central or national administrative level. This is the brain of the operation, right?
Exactly. They sit in the capital.
They are recommending national policies, managing the massive tertiary care hospitals, and running the national training institutions.
And because the scope of responsibility at that central level is entirely macro, the workforce here requires the most intensive, longest duration training.
We're talking master's degrees, PhDs, specialized medical fellowships.
Right. They are the systems architects. However, despite holding the ultimate systemic authority and, crucially, the budget control.
They hold the purse strings.
Yep. This tier actually features the smallest absolute number of public health workers.
Which naturally forces a huge reliance on level 2, the provincial health departments.
The middle managers of the system?
Exactly. If the central level is the brain, the province is the central nervous system trying to push those signals out to the limbs. They have to translate these lofty, abstract national policies into implementable reality across really diverse regions.
And they run the provincial hospitals that take the heavy clinical referrals.
Right. But their most vital function regarding capacity building, according to the text, is that they are responsible for conducting the regional training programs for the local tiers beneath them.
They are the primary educators for the operational frontline. And this is a huge friction point. Because if the provincial department lacks the resources or the pedagogical skill to train the district workers properly, the national policy simply dies in translation. It never reaches the ground.
Wow. And that brings us to the ground. Level 3, the district or local level.
Right.
The text states a typical district health center might serve a population of 5,000 to 10,000 people.
Sometimes way more, honestly.
Yeah, and this is where the abstract concept of public health becomes a physical reality. Vaccinations actually going into arms, maternal checkups, outbreak containment,
But the textbook doesn't even stop at the district. It pushes us further down to the absolute periphery.
The village level.
Yes, staffed by volunteer health workers.
The HWs.
Right. And these individuals are not transient medical missionaries who fly in for a week. They are drawn directly from the local population.
They live there.
They live in the village, they deeply understand the microculture, and their operational scope is highly intentionally differentiated.
I noticed that strict differentiation. The text explicitly outlines their clinical boundaries.
Yeah, it's very specific.
They might only receive a few weeks of formal training. So they provide basic first aid, they monitor medication compliance, and they serve as the primary referral mechanism to send people up to the district clinic.
Right.
And crucially, they are permitted to administer oral vaccines, like the polio drops,
Yeah.
and high-dose vitamin A,
Yes.
but they are strictly prohibited from giving any injections.
And that limitation is just a brilliant example of systemic risk management.
Why is that?
Well, administering an oral drop is a high-reward, low-risk intervention, right? It has massive population-level benefits. But administering an intramuscular or intravenous injection, that requires rigorous sterile technique.
Which is hard to guarantee in a village setting.
Exactly. It requires the safe logistical disposal of sharps and the clinical capacity to immediately manage severe adverse reactions like anaphylaxis.
Right, if someone has an allergic reaction to a shot, you need epinephrine ready to go.
And a volunteer with 3 weeks of training doesn't have that. If you allow village workers to give injections without continuous training and a flawless supply chain for sterile equipment, you introduce a massive iatrogenic risk.
Iatrogenic meaning illness caused by medical examination or treatment.
Right. You could inadvertently trigger localized outbreaks of bloodborne pathogens like hepatitis or HIV just from reusing needles. So the system is matching the intervention strictly to the capacity of the workforce.
That structural boundary makes total clinical sense. But what I found intellectually fascinating was the incentive structure for these volunteers.
Oh, prestige factor.
Yes, because we are so conditioned to view compensation through a purely monetary lens. You do work, you get a paycheck.
Especially in Western systems.
Exactly. But the text notes that for a volunteer health worker, the primary reward isn't a salary. It's prestige.
Yeah.
The social capital of being the recognized health authority in a localized setting is the actual currency driving this entire base layer of the public health grid.
It is a profound realization about human behavior in resource-limited settings. I mean, the central minister in the capital city might design the grand strategy, but that volunteer health worker operating almost entirely on institutionalized prestige, they hold the most intimate, real-time epidemiological data in the country.
Because they see everyone every day.
Exactly. They know who is showing signs of a persistent cough. They know whose child missed their oral polio drops. They know which families are struggling with food insecurity.
Right.
Without the village level's localized intelligence, the central level is essentially flying blind. They're making policy based on ghosts.
But, okay, bridging that gap between the local intelligence of the village and the grand strategy of the capital requires the district level to function flawlessly.
It does. They are the bridge.
And reading the text, it seems the district level is actually in a state of chronic structural collapse.
Yeah, the text refers to this as a severe congruency crisis.
Okay, unpack that congruency crisis.
Congruency in this context refers to the alignment between what a professional is formally trained to do and what the systemic reality actually forces them to do to prevent a total collapse.
Here's is where it gets really interesting. Let's look at the nurse midwives and the allied health personnel operating at that district tier.
Okay.
The asymmetry of resource allocation here is staggering. These professionals typically possess only 1 to 3 years of formal training,
Right.
yet they carry the absolute weight of the entire public health mandate on their shoulders.
The burden of task shifting placed upon them is monumental.
Task shifting.
Yeah, task shifting occurs when specific tasks are moved, where appropriate, to health workers with shorter training and fewer qualifications. Now, in a well-resourced system, like in the US or UK, it's an efficiency measure.
Like a nurse practitioner handling routine checkups.
Exactly. But in a developing district context, it is a raw survival mechanism. A nurse midwife with perhaps 2 years of training is managing complex, obstructed deliveries entirely alone. They are staffing the antenatal clinics, they are driving the logistical execution of massive regional immunization days, and they are administering directly observed therapy, or DOTS, for tuberculosis and HIV.
And DOTS demands immense administrative tracking, right?
Huge amounts, and clinical diligence to ensure patients take every single pill, because if they don't, you breed drug-resistant strains.
I was trying to conceptualize the sheer pressure of that environment. The text notes, a single nurse midwife might be covering 10 to 15 different villages.
It's unbelievable.
Imagine standing in a remote clinic, recognizing the signs of an obstetric hemorrhage. You have the diagnostic knowledge. You know this patient requires an immediate referral to a provincial station hospital for surgical intervention.
You know what needs to happen.
But the text cites transportation as a massive systemic bottleneck. You have the training to recognize the emergency, but you have no ambulance, no fuel, or no passable road to actually execute the referral.
It's heartbreaking.
The infrastructure completely nullifies the training.
Which forces the provider into an impossible ethical and clinical corner. I mean, the training is a prerequisite, obviously, but without the physical infrastructure to support the referral pathways, capacity building just hits a hard ceiling.
Yeah.
And those structural cracks aren't just logistical. They severely compromise the diagnostic integrity of the entire nation.
I want to dig into that because the section on laboratory quality control was genuinely alarming to me.
Oh, the lab gap. Yeah.
The text discusses the station hospitals and provincial laboratories. These higher tiers are supposed to be the analytical backstops for the districts,
They are supposed to be, yes.
but they frequently operate without any standardized quality control procedures or routine proficiency testing.
And the implications of that gap extend far beyond a single misdiagnosis of one patient. A national epidemiological surveillance system is fundamentally only as valid as its local assays.
Garbage in, garbage out.
Exactly. If a provincial laboratory is operating without strict quality control, say, their reagents have degraded in the heat because the fridge broke, or if their microscopes are uncalibrated, or if the technicians haven't received refresher training on novel pathogens, they will inevitably generate massive amounts of false positives and false negatives.
And because that data feeds upward, it corrupts the entire central nervous system.
Precisely. The central ministry is sitting there attempting to track the prevalence of drug-resistant TB or monitor a budding viral outbreak.
Right.
But they are receiving completely corrupted data from the provinces. Consequently, the national policymakers allocate their scarce millions, they deploy personnel, and they design interventions based on a completely fabricated epidemiological reality.
That is terrifying.
You cannot build evidence-based policy on top of uncalibrated microscopes. The lack of continuous training for a provincial lab technician directly blinds the national health minister.
The electrical grid metaphor holds up again. A blown transformer at the provincial level doesn't just mean the local lights go out. It sends a surge back up the line that corrupts the entire central control board.
So, given these severe constraints in continuous training and quality control, how does the system actually attempt to upskill its workforce?
Well, the text mentions a modern trend that seems like an obvious solution on paper.
Distance learning.
Yes, the massive rise of internet-based Master of Public Health, or MPH, distance learning programs targeted specifically at developing nations.
Right.
But based on the tactile, infrastructure-dependent realities we literally just discussed, I have serious reservations about this.
I think the text does too.
I mean, I understand that distance learning is incredibly efficient for teaching, say, biostatistics or the mathematical modeling of epidemiology.
Sure, things you can do on a spreadsheet.
Exactly. But you cannot learn how to negotiate with a village elder to secure permission for a vaccination campaign, or how to manage the chaotic logistics of a rural cholera outbreak from a laptop in an air-conditioned internet cafe in the capital city.
No, you definitely can't.
Does this not risk perpetuating the exact same disconnect as the colonial curricula? It's high-level theory, entirely divorced from the dirt and reality of the field.
It absolutely does, and the textbook explicitly acknowledges that vulnerability. It cites the lack of, quote, hands-on field experience as the critical structural flaw of purely online distance learning in this specific field.
Because it's so tactile.
Public health implementation in a developing context is deeply cultural, it's political, and it's tactile. However, the text proposes a synthesis rather than just a total rejection of online learning.
Oh, like a hybrid model.
Yeah, it suggests utilizing web-based discussion groups that mandate connection between these distance learners and actual seasoned local practitioners.
Oh, I see.
It attempts to tether the academic theory back to the localized operational reality, creating a feedback loop between the academic models they are learning online and the actual field data.
It's an attempt to force the theorist to talk to the mechanics. That transition from theory to practice naturally leads us to look at the educational pipeline itself. Who actually gets to make these decisions?
Well, at the highest levels of the system, there is essentially a medical monopoly.
A medical monopoly.
Yeah. The text details that formal medical degrees are almost universally mandatory for anyone looking to secure provincial or national leadership roles or to run district hospitals.
You have to be an MD.
Usually, yes.
Okay.
A medical degree or a highly specialized clinical degree is often the rigid prerequisite even to enter those advanced master public health programs.
But wait, by mandating a medical degree for public health leadership, you are building your system on a resource that is already critically scarce.
Yep.
There are never enough doctors, especially in rural districts. To counteract this, the text mentions that many developing nations implement a policy of mandatory rural service.
Yes, very common.
They basically force newly graduated physicians to work at a district or rural level for a set number of years before they are legally permitted to specialize or practice in the affluent urban centers.
It is a highly prevalent structural mechanism to force resource distribution. They need bodies in the rural clinics.
I mean, it functions exactly like a systemic tourniquet.
Tourniquet.
Yeah, it is an aggressive temporary measure applied to stop the immediate bleeding, the critical shortage of clinical coverage in the districts.
Right.
But a tourniquet is not a cure, and it eventually causes tissue damage. What happens when the 2-year mandatory service is up?
They leave.
The physician leaves immediately for the city or the private sector. The pressure drops right back to zero, and the district clinic is right back where it started, waiting for the next reluctant, resentful graduate to be parachuted in.
The tourniquet analogy is conceptually accurate regarding the temporary cessation of the shortage, but you rightly identify the long-term failure there.
It doesn't fix the underlying problem.
Not at all. A coerced temporary deployment does not build a dedicated public health professional who is deeply invested in the sociological and epidemiological fabric of that specific community.
They're just counting down the days.
Exactly. It maintains bare minimum clinical coverage, but it actively prevents sustainable capacity building. And this pipeline problem compounds severely when we evaluate the capacity for advanced local research.
The text highlights a terrifying reality regarding research. To create robust disease surveillance systems, or to objectively evaluate the efficacy of national health policies, you need advanced local training, usually at the PhD level.
Right.
But because domestic research funding in these nations is almost non-existent, most of their public health programs are fundamentally not evidence-based.
Which is a huge blind spot. If a nation lacks the financial architecture to train indigenous researchers to evaluate their own local data streams, they are forced to operate on assumptions.
Or borrow from elsewhere.
Yes. They must rely on policy frameworks and interventions designed by external international bodies. Frameworks that may be statistically valid in a global cohort study conducted in Geneva or Atlanta, but are completely misaligned with the specific cultural and infrastructural context of the host nation.
Right, because the variables are totally different.
Without the capacity to generate local, rigorous evidence, the system cannot optimize itself. It can only blindly adopt external mandates.
Wow. We are accumulating a massive list of systemic friction points here.
You really are.
We have the staggering mandate, the historical mismatch of colonial curricula, the heavy task-shifting burden on undertrained district workers, the collapse of lab quality control, the tourniquet of mandatory service, and a total lack of localized research funding.
It's a heavy load.
When you synthesize all of this, you arrive at the core systemic bottlenecks in providing public health training.
And the primary bottleneck identified in the text is the severe disconnect between expectation and preparation.
Meaning what they were asked to do versus what they were taught to do.
Exactly. Health workers deployed to the periphery are expected to investigate complex outbreaks, manage supply chains, and execute community health education. Yet, their formal training rarely covers these specific practical logistical competencies.
Right.
Furthermore, the training they do receive is frequently siloed.
Siloed in what specific way?
It is functionally reductionist. So, a worker might be rigorously trained to execute one specific vertical task flawlessly. For instance, administering the DOTS protocol for a tuberculosis patient.
Okay.
But they lack a holistic, horizontal understanding of the health system. They do not understand how their localized tuberculosis data feeds into the National Epidemiological Registry or how their work impacts broader systemic resource allocation.
They only see their one puzzle piece.
Right. They are trained to be a functional cog, but they do not understand the machine. And when the machine experiences an unexpected shock, a novel pathogen, a supply chain collapse, they lack the system's thinking required to adapt.
And frankly, even if they possessed a perfect holistic understanding of the systemic machine, their primary focus is often entirely diverted by their own economic survival.
Oh, absolutely.
The text is brutal about the economic reality of public health funding. It states unequivocally that public health is frequently a low political priority for governments.
Because it doesn't win elections like a shiny new hospital does.
Exactly. And because it lacks political leverage. The public health workforce is paid terribly.
Which introduces one of the most corrosive phenomena in global health systems. Dual practice.
I was reading about dual practice, and my initial naive thought was, if the wages are that unlivable, why don't they just quit the public sector entirely?
That would be the logical assumption.
But the reality is much more insidious, isn't it?
Yeah.
It means the system is literally relying on the exhaustion of its doctors.
It creates a massive structural conflict of interest. Consider a highly trained physician or senior nurse who genuinely possesses a public service ethos. They want to serve the district hospital.
They want to help.
But the government salary is mathematically insufficient to feed their family or pay for their children's education. So, to bridge the gap, they are forced to establish and run a private clinical practice alongside their public duties.
Hence, dual practice.
Right. And this dual practice splits their cognitive load, it drains their physical energy, and ultimately degrades the operational efficiency of the public system.
Because they're working two full-time jobs.
Exactly. They may even inadvertently or intentionally divert public resources or refer paying patients from the public clinic to their private practice.
Why?
The individual is not necessarily malicious. They're just executing an economic survival strategy within a system that refuses to compensate them adequately.
And when the exhaustion of running two practices becomes too much, or when the disparity between their skills and their compensation becomes intolerable, they simply leave the country.
The brain drain.
Which brings us to the most infuriating economic bottleneck detailed in the chapter. The brain drain. We are talking about the mass migration of highly trained doctors, nurses, and allied health professionals from the developing world to wealthy nations like the US, the UK, or Australia.
And the macroeconomic implications of this migration are just devastating.
Don't have it.
Developing countries operating with incredibly constrained GDPs allocate their scarce sovereign wealth to educate and train healthcare professionals through medical schools and nursing programs.
They pay for the training.
They bear the entire foundational cost of capacity building. And the moment those professionals reach peak clinical and operational utility, they migrate to seek better pay, safer working conditions, and functional infrastructure.
I had to stop and reread that section because the economic math is just a breathtaking inequity.
It really is.
The developing world is fundamentally subsidizing the healthcare systems of the wealthiest nations on Earth.
The textbook underscores this exact dynamic. High-income countries reap the benefit of a fully trained, highly competent workforce without having to invest in the decades of foundational education and clinical training required to produce them.
They get them for free, essentially.
Exactly. Meanwhile, the low-income countries bleed the exact intellectual and operational talent they desperately require to build their own systemic resilience. It is a massive structural transfer of wealth and capacity from the poor to the rich.
And the final insult to that injury is that the domestic public health programs that do manage to survive this talent hemorrhage are often heavily subsidized by international donors.
Which introduces the concept of donor misalignment.
Yes.
International donors, whether they are bilateral foreign governments or massive multi-billion-dollar philanthropic foundations, rarely give unrestricted funds.
They don't just write a blank check.
Never. They arrive with highly specific, vertically integrated health agendas. They may be mandated by their boards to focus exclusively on HIV/AIDS antiretroviral distribution or solely on malaria eradication metrics.
Right. They want to fund the sexy diseases that produce clean data sets they can put in an annual report.
Exactly. But that specific donor agenda frequently clashes violently with the actual localized epidemiological needs of the host country.
Like our midwife from the intro.
Exactly. The host nation might be experiencing a catastrophic spike in maternal mortality due to a lack of basic surgical infrastructure, or a surge in chronic respiratory disease from indoor cooking fires.
But the donor only cares about malaria.
And because the national government is desperate for capital, they contort their health system. They divert their limited domestic personnel, their supply chains, and their political capital to match the donor's priorities.
So they ignore the maternal mortality to chase the malaria metrics.
Yes. The donor funding acts as a massive power surge on the grid, blowing out local capacity to deal with anything other than the donor's chosen disease.
Man. So we have mapped a diagnostic landscape that is incredibly grim.
It's heavy.
We have a system that is fundamentally underfunded, saddled with mismatched colonial curricula, bleeding its best talent to London and New York, hijacked by the vertical agendas of foreign philanthropists, and held together by exhausted district nurses and village workers paid entirely in social prestige.
When you list it all out like that, it sounds impossible.
How does a nation actually engineer a way out of this? What are the textbook's blueprints for change?
The chapter transitions from diagnosis to a highly specific sequenced strategic framework for systemic repair.
Okay, let's hear it.
It argues that you cannot fix the retention or the brain drain until you fix the foundational alignment. And that requires a 4-step intervention, beginning with comprehensive needs assessments.
But wait, how do you actually conduct a valid needs assessment in an environment where the local ministry knows the foreign NGO only wants to hear about malaria? Doesn't the money instantly corrupt the assessment?
That is a great question, and it's the exact friction point the text attempts to address by insisting on active community participation.
Active community participation.
Yes. A valid needs assessment cannot be conducted via a spreadsheet in the capital city, and it cannot be reverse engineered to appease a donor.
Right.
It must be conducted at every single tier of the system, starting at the village. You have to utilize epidemiological surveys, focus groups, and local intelligence to determine what the community actually requires to survive.
So if the data says they need clean water and emergency obstetric transport, that must be the documented need, regardless of external pressures.
Exactly. Because that verified need forms the foundation for step 2, job descriptions.
Job descriptions.
Yeah.
Okay.
You cannot write a job description based on a European template or a donor's fantasy. You formulate highly specific, formally documented roles based strictly on the localized needs assessment.
So you define exactly what the district nurse must be capable of doing in that specific geography.
Yes. And only once you possess that localized, highly specific job description do you move to step 3, curriculum design.
So the curriculum is built backwards from the job description.
Exactly. You build the educational architecture explicitly to match those newly documented roles. This is the structural mechanism to solve the congruency problem we talked about earlier.
Right, the gap between training and reality.
You cease training professionals for highly resourced scenarios they will never encounter, and you rigidly train them for the exact logistical, clinical, and administrative tasks their specific community requires them to perform. You align the training with the reality.
And the linchpin to making that curriculum work is step 4, faculty selection.
Spot on. You must aggressively recruit instructors who possess actual tactile field experience, delivering services at the specific level they are teaching.
Which makes total sense.
It is functionally useless to have a national-level academic whose career has been confined to a tertiary hospital in the capital, attempting to instruct a district-level nurse on how to manage a rural vaccination campaign during a monsoon.
Yeah, they wouldn't even know where to start.
The faculty must reflect the operational reality of the grid they are training people to maintain.
It is a brilliantly logical 4-step sequence. Needs assessment, job description, targeted curriculum, experienced faculty.
Yes.
But, logic doesn't pay the rent.
No, it doesn't.
You can build the most perfectly contextualized training program in the world, but if you don't address the economic survival of the workforce, they will simply take that excellent training and migrate anyway. Retention strategies seem like they have to be built into the system before a single student is even enrolled.
The text emphasizes exactly that. Clear, transparent career tracks must be visible to prospective students before they enter the field.
They need a ladder to climb.
Right. If a junior professional cannot map a logical pathway to advancement, specialization, and increased authority, they will divert their career away from public health entirely.
And we have to talk about how the system incentivizes them to stay on that track. We discussed dual practice, which is driven by a lack of monetary compensation.
Yeah.
Paying a livable wage is the baseline requirement.
Yeah.
But I want to circle back to the village worker and that concept of prestige, because the text expands on this. Non-monetary incentives are not just a nice bonus, they are a structural requirement.
They are critical levers for retention. The text highlights that recognition of worth, professional autonomy, and social prestige are deeply powerful motivators. It is about institutionalizing respect.
Institutionalizing respect. I love that phrasing.
If the central ministry treats the district nurse and the village volunteer as highly valued, strategically vital pillars of the nation's security, rather than just expendable, low-level laborers, that recognition fundamentally alters the retention calculus.
It changes how they view themselves.
Exactly. When a worker feels their expertise is respected and utilized, their tolerance for systemic friction actually increases. Institutionalizing respect is a zero-cost structural retention strategy.
And the final piece of this architectural blueprint is continuous evolution.
Because nothing stays the same.
Right. The epidemiological landscape is never static. A nation might successfully utilize this framework to conquer polio, but 10 years later, they face an explosion of cardiovascular disease and diabetes.
Yep, the epidemiological transition.
Therefore, the system must mandate periodic monitoring and reevaluation of its training. Programs cannot remain static. They must adapt, utilizing robust postgraduate and refresher courses to prevent skill stagnation.
If the workforce does not evolve at the same speed as the pathogen and the population, the entire health system becomes obsolete.
To synthesize our entire conceptual map today, capacity building in a low or middle income setting is not merely an educational endeavor.
No.
It is structural engineering. It is the literal construction of the electrical grid.
Yes.
An effective, resilient public health system requires ruthless alignment. It requires matching actual localized needs with highly specific, field-tested training.
Right.
It demands the establishment of clear, visible career pathways. And it relies fundamentally on institutional respect and aggressive retention strategies to maintain its structural integrity against the corrosive forces of brain drain, donor misalignment, and poverty.
That structural reality fundamentally changes how you view a rural clinic. It is not just a building. It is the final, fragile point of intervention in a massive, systemic struggle.
It really is. And before we move to our learning reinforcement, I want to leave you, the listener, with a provocative question based on everything we've mapped today.
Let's hear it.
We discussed the massive power surge of donor misalignment.
Yeah.
If global health funding continues to operate primarily on these vertical, disease-specific donor agendas, say, a philanthropic grant drops from the sky, but it is earmarked exclusively and inflexibly for malaria.
Right.
How can a developing nation strategically and forcefully redirect or leverage those vertical funds to build the unsexy but absolutely essential horizontal infrastructure?
Ooh, that's the million-dollar question.
Right. How do national planners use malaria money to fund reliable laboratory quality control for all pathogens, or to institutionalize the training and prestige of the village worker?
Because they have to.
Because ultimately, it is that baseline horizontal infrastructure that will not only manage the malaria, but will be the very system that catches and stops the next unexpected pandemic.
It requires immense political leverage and strategic negotiation by the host country to force donors to invest in the grid, rather than just plugging their specific appliance into it.
It is a critical question for the next generation of public health leadership to mull over. Now, to ensure the structural frameworks we've built today stay firmly anchored in your memory, we're going to transition to our learning reinforcement session.
Time for the rapid recall.
Yes, this is designed for rapid recall of the core mechanisms from the textbook. I'm going to read a single best answer prompt based on Chapter 11.8, pause briefly so you can actively lock in your clinical or systemic reasoning, and then I will provide the correct answer and the section reference for your continued study.
Let's lock these concepts in.
Question 1. Which tier of the public health system is primarily responsible for the translation of national policies into regional action, receiving complex clinical referrals from districts, and conducting vital regional training programs for local health professionals? Answer: the provincial level. You can review the functional responsibilities of this tier in the section titled Typical Public Health Structures in Developing Countries. Question 2. In the context of differentiated scope of practice, a volunteer health worker operating at the village level is generally permitted to perform which of the following specific clinical activities? Answer: administering oral vaccines and high-dose vitamin A, but strictly not administering injections, due to the severe iatrogenic risk without continuous training and sterile supply chains. Reference the section on typical public health structures. Question 3. According to the chapter's historical analysis, what is the primary structural root cause of the mismatch between formal public health training curricula and the actual population health needs in low and middle income nations? Answer. The enduring legacy of curricula developed by European colonialists, which were fundamentally based on European models of disease and infrastructure, failing to contextualize for local realities. This is detailed in the Introduction to Training of Public Health Professionals. Question 4. Which term best describes the macroeconomic systemic effect that occurs when highly skilled healthcare workers, trained at the expense of low-income nations, migrate to practice in high-income nations? Answer. Developing countries are effectively subsidizing the foundational healthcare education and systems of developed countries. You'll find this sobering systemic analysis in the section on Strategies to Overcome Barriers to Optimal Public Health Training. Question 5. To definitively solve the congruency problem in workforce training, what foundational sequential step must be completed prior to the design of a targeted educational curriculum? Answer. Conducting a thorough community-based needs assessment and utilizing that data to document formal, highly specific job descriptions at every level of the system. This structural blueprint is detailed in Strategies to Overcome Barriers. And that concludes our conceptual mapping of Chapter 11.8. We highly encourage you to read the full source chapter in the Oxford textbook of Global Public Health to consolidate these frameworks.
It's an essential read.
Remember, the pathology of a failing health system is just as complex and requires just as much rigorous diagnostic attention as the pathology of any disease. Keep questioning the structure, keep studying, and we will see you on the next deep dive.
Thank you for listening. Here are the details of this episode.
Training Public Health Professionals, Developing Countries. Title: Training Public Health Professionals, Developing Countries. Byline: Medlock Holmes explores capacity building in low and middle income settings, strengthening workforce, leadership, and institutional resilience. Episode description: Effective public health systems depend on skilled professionals capable of surveillance, program design, outbreak response, policy analysis, and leadership. In many low and middle income countries, workforce shortages, migration, limited training infrastructure, and funding constraints pose significant challenges. This chapter examines strategies for developing public health capacity, including field epidemiology training programs, academic partnerships, in-country institutional strengthening, mentorship, and leadership development. It considers sustainability, retention, and the importance of contextualized training aligned with local needs. Training is framed not as isolated education, but as system investment. Strengthening public health professionals strengthens governance, preparedness, and long-term resilience. Capacity building is prevention at the structural level. Key takeaways: workforce shortages limit public health system performance. Field epidemiology and applied training improve outbreak response capacity. Sustainable in-country training reduces dependence on external expertise. Leadership development strengthens governance and accountability. Retention strategies are essential to prevent workforce migration. Context-specific curricula improve relevance and impact. Capacity building underpins long-term system resilience.